Imagine, like, a patient comes into the ER, they have a headache, maybe a fever. You check their neck for stiffness, the classic sign of meningitis. It feels totally fine, so you send them home.
You might have just made a fatal mistake.
Exactly. Today, we're built like an ironclad algorithm for how you can accurately diagnose and treat this really high-stakes infection.
Yeah, and to build that algorithm, we actually have to start by unlearning some pretty fundamental teachings. I mean, the traditional diagnostic approach is dangerously flawed.
Okay, let's get right into that. If you've been around medicine, you definitely know the classic meningitis triad, right? Fever, neck stiffness, and altered mental status.
Oh, yeah, and you throw in the Kernig and Brudzinski tests, too.
Right, where bending the patient's hip or neck causes severe pain. If you see those, you're supposed to just have your diagnosis.
But the problem is, the text emphasizes that these classic signs have terrible sensitivity. We're talking like under 33%.
Wow, under a third.
Yeah. They typically only show up when the disease is already extremely advanced.
So relying on them to rule out meningitis is basically like using a smoke detector that only works a third of the time. It just gives you this complete false sense of security.
That's a great way to put it.
So if those classic signs are out, what should you actually be looking for?
Well, the most sensitive general symptoms are honestly just headache and nausea. But the text highlights this very specific physical check called the Jolt Accentuation test.
The Jolt Accentuation test, what is that exactly?
You basically have the patient rapidly rotate their head horizontally at about 2 rotations per second.
Oh, okay, which violently stretches and irritates the meninges around the brain.
Exactly. If they're already inflamed, that rapid movement is going to cause a massive sudden spike in pain.
That makes total sense.
Yeah, and the text notes that if a patient has a fever and headache, a positive Jolt accentuation test actually has a nearly 100% sensitivity for increasing the probability of meningitis.
100%. That's incredible. Okay, so the head jolt makes us highly suspicious. But, I mean, we can't just start blasting a patient's brain with heavy medications on suspicion alone.
No, definitely not. You need definitive proof.
Right, which usually means a lumbar puncture, tapping the spinal fluid. But here's where I'm a bit hung up. Modern protocol usually dictates that we almost always run a CT scan before sticking a needle into a potentially pressurized spine.
Right, to avoid causing a fatal brain herniation.
Exactly. So how does the textbook handle that?
Well, it explicitly tells you to abandon that safety net in most of these cases. It says to just skip the CT scan.
Wait, really? Just go in blindly with the LP? I mean, we CT scan almost every severe headache to, rule out pressure issues. Why abandon that rule here?
Because the underlying issue is time. Waiting for a CT scanner delays life-saving antibiotics.
Oh, I see.
Yeah, you only pause for a CT if the patient has specific red flags that make herniation an immediate, highly probable threat.
What kind of red flags are we talking about?
Things like immunosuppression, a history of central nervous system disease, focal neurological deficits, or a recent seizure. If they don't have those, you just go straight for the fluid.
Got it. And once we actually have that cerebrospinal fluid, we're looking for the classic profile, right? Like cloudy color, high opening pressure.
Yeah, low glucose and high white blood cells and protein.
Right. And the underlying causality there is pretty brutal. The glucose drops drastically because the multiplying bacteria are literally consuming the brain's sugar supply to fuel themselves.
It is brutal, and meanwhile, the protein spikes due to the massive influx of white blood cells, plus the actual debris of dying bacteria filling up the fluid.
Jeez. Which brings us directly to the treatment phase. We've got the proof the bacteria are eating the sugar, and the text lays down a golden rule here. Never, ever delay antibiotics to wait for the LP.
Absolutely never. If the spinal tap is difficult or, say, the room just isn't ready, you push the medications anyway.
Because you just have to strike fast and with overwhelming force.
You do. Meningitis requires exceptionally high antibiotic doses just to penetrate the blood-brain barrier.
How high are we talking?
We're talking 2 grams of ceftriaxone for typical adults, and then you layer it based on suspicion. You'd add vancomycin to cover MRSA or ampicillin if you suspect listeria.
Okay, heavy hitters. I also noticed dexamethasone in the protocol. If we're throwing heavy antibiotics to kill the bacteria, why add an immunosuppressant to the mix? That seems backwards.
It does seem counterintuitive, yeah. But it's really about managing the fallout. Dexamethasone doesn't actually reduce the mortality rate of the disease.
It doesn't.
No. What it does is blunt the massive, devastating inflammatory response caused by the bacteria as they die off and burst open.
Oh, I see. So the antibiotics are killing them, but their death causes a huge reaction.
Exactly. By suppressing that specific inflammation, dexamethasone prevents permanent neurological damage, most notably severe hearing loss.
Wow, that's fascinating. So to synthesize the whole algorithm for U-test with Jolt Accentuation, not just neck stiffness,
Yeah.
perform an LP immediately, skipping the CT unless you see those very specific red flags?
Right, and blast the infection with high-dose antibiotics and dexamethasone without a single second of delay.
It's a really aggressive, fast-paced protocol. But I guess it's exactly what's required to outpace an infection that lethal.
Definitely. It's the only way.
It really makes you wonder, though, if the classic triad we've been taught for decades is this dangerously unreliable, how many other traditional medical exams are secretly failing doctors in the ER every single day?